we are the mainstream rehab providers. And we don't want to, in my mind, lose that. So if the rest of the mainstream medical providers are learning how, and various stages, some haven't started yet, but if they're learning how to work as a partner with payers, as a partner with anyone taking financial risk, right, another provider type, then we have to be also. Kick it.
Welcome to Strata Stories. My name is Thomas Schreiber. I'm Director of Marketing here at Strata PT. Strata PT is a single EMR platform and a revenue cycle management service for physical, occupational, and speech therapy practices that helps you achieve a 99.99% reimbursement rate. On today's episode, Paul Singh, the CEO of Strata PT, talks with Dana Strauss, who is a PT and the Senior Director of Government Affairs at CVS Health. Paul and Dana discuss leveraging data to identify cost-saving opportunities, collaborating with primary care providers in value-based contracts, and piloting small-scale programs to test value-based care models. If you'd like to learn more about Strata PT and see our EMR and RCM works, head over to stratapt.com to book a demo. Now, without further delay, here's today's episode.
For anybody listening right now, let's not worry about who you voted for or who anybody voted for. But for practice owners and healthcare professionals, and I don't think patients listen to our show, but for everybody involved, we kind of know what the next 4 years are going to look like. And I gotta believe, knowing you enough to know, Dana, that you probably have some opinions about what the next 4 years are looking like. So let me just prompt you and see where you go with this. So for the average practice owner, physical therapy, occupational therapy, speech, all those things, for the average practice owner now, we're in November of 2024, the election's done. What are your thoughts about the next 4 years in terms of, and I'm leaving this as a broad question to see where you go with it. What should practice owners be paying attention to? What are the opportunities? Let me just leave it broad and see where you go with that.
Yep. I think it's good and bad for practice owners, and I'll explain why. First, I'll say it's generally one of the most positive things about the outcome of the election. This is not speaking about, again, has nothing to do with how you feel politically on any side, and none of this is going to be political. It's about what we know about the candidates that we're running, what we know about them historically, and what we know about the appointees that we're seeing. So where I sit from wanting to see value-based care policy continue to progress, while value-based care came from the Affordable Care Act, it came from the Obama administration. What we know about the Affordable Care Act is it can't be overturned. It's way too popular. And some of the things about the Affordable Care Act that really impact the work that I do and what I believe in have a lot to do with the CMS Innovation Center. They've driven a lot of the progress we've made, a lot of the interesting testing we're doing in terms of looking at how we pay for models, we pay for different types of care that's provided. And so what we expect from a Trump administration just overall is going to be a very pro Medicare Advantage, very pro full risk. And so what I mean by that is, if I'm the Center for Medicare, if I'm the HHS secretary in a Republican sweep, what generally, and we don't, again, I am going to caveat this to death. There's no way for me to predict the future, but I'm going to go by generalizations and things that we know or historically have seen. Republicans like to take risk and spend of the administrative work off the government and put it onto the private sector, right? So Medicare Advantage is generally, it's gaining in popularity everywhere, and we have people from Florida to Oregon to everywhere in between signing up for Medicare Advantage. So it's popular in and of itself, but the Republican Party is very pro MA. There are some things that they want to tweak about it and change and fix, but they're pro MA. And they're interested as a whole in value-based care because it's very bipartisan. It reduces spend, it improves quality, and we know that. But this is the party that's going to take fewer small steps and push big steps. So things like all of what I've talked about in prior podcasts and what I write about, putting the risk onto providers, saying, providers, right, we're just going to give you, if you're willing to get into a contract with us, we're just going to give you all the dollars to pay for all of the care, and you have to figure out how to do the right thing so that you make money and definitely don't lose money.
Right.
And when you do that in Medicare Advantage, that's the first step. In Medicare Advantage, the plan takes over. In Medicare Advantage, plans get into contracts with providers of all kinds, right? But then in fee for service, we're talking about the Medicare Shared Savings Program, the ACO REACH model, and what comes next. Those are direct contracts between providers and CMS and any other payer, right? I mean, a provider can get into any relationship in depending on what's available in their area or what's available in the payers that they work with, but they can get into a relationship with the payer directly, and that payer can directly be CMS.
Yeah.
So on the fee for service, the traditional Medicare side, we're going to see more than likely a push towards taking more risk. We might even see a mandatory requirement for taking on some level of risk or within some period of time. What we've seen in the Biden administration has been, yes, we're going to give a lot of incentives to get into risk, but we're going to make the runway long. So you can join the Medicare Shared Savings Program, which is exactly what it sounds like. You share in the savings that you create with between the patient and yourself and the care you're providing. But we're not going to let you stay in upside only. We're going to push you quickly into downside risk. So you're going to put your money where your mouth is, in other words. This is kind of very traditional Republican versus Democrat thinking, but with a sweep and having 2 years probably before something changes, having a sweep of government. And now we have Mehmet Oz, right? And Mehmet Oz is very pro-MA. I mean, he wants to privatize all of healthcare. And this is so important for your audience and for therapists in general is Medicare Advantage is a touchy subject. Obviously, we've talked about that before, but it's really difficult for outpatient providers in particular of all kinds, physicians, therapists, you name it, behavioral health. Their rates are just not necessarily as high as in fee for service. This also impacts places like skilled nursing facilities and patient rehab facilities. The more Medicare Advantage infiltrates, the more those businesses are strained because they're paid so significantly more in fee for service. So when we're moving to more MA, that's tough. And providers, in my mind, we're getting past the point where it's optional, that you know how to work with payers in a different way and can find unique ways to contract with them. And in fee for service, if we're going to move towards a full risk or a higher risk fee for service environment, again, you need to understand the programs that are set. In Medicare Advantage, they can create whatever they want. They have a lot of flexibility. In fee for service, these are programs developed by the federal government. And so you need to understand those programs inside and out so that you can then go to those who are in those programs, or you can join those programs and take advantage. Because it's going to be either you're well in, or you're out on the outside waiting for more cuts. I mean, that's kind of, anyway, let me stop there. I know I said a lot.
No,
as usual.
Well, and just like I said to you in the pre-show, I think you have a way of making these topics way more accessible, and I admit, like, I'll sit there and I'll watch the nightly news and I'm like, yeah, this seems like a lot's happening. I don't know exactly how this affects anybody I know, but you just, you sort of effortlessly sort of explain that. I guess, so the part that I kind of want to keep, and again, I keep telling you that I feel like a second grader sometimes talking to you, and there's a compliment in there somewhere, but for you anyways, I should say. But I guess, like, the part I want to peel back a little bit more is, like, if this is a topic you don't want to touch on, we can always, like, edit this out in the end there. But, I don't want to give away the idea that you kind of brought up or that you shared with me before. But, as you think about the next 4 years, the next 2 years, kind of how you described it, what are some of the tactical things that you think a practice owner should be doing here? Because I don't know how to articulate this, so let's just see where this goes. You've met a couple of our customers, and you've talked to those owners, and I won't make you say anything embarrassing about any of them, but I feel pretty comfortable saying that most of them are just they're busy running their business. They probably broadly agree with you on sort of your thoughts, and kind of, and they're listening to what you're telling them to do in terms of next steps. But for a busy practice owner listening to this now, are there tactical things they should be doing? Like, are they, I don't know, like, so you've said in previous episodes with us, you've said things like, we need to get more practice owners sitting at the table with these policymakers. And those are, actionable things. It's a tactical thing. Are there other tactical things like that practice owners should be thinking about as it relates to, these next 2 years of the changes that we're going to see?
And right, a lot of this is, unfortunately ends up side of desk. And so there is this kind of, you know, I don't want to say knowledge gap, but I see it as, and translate this maybe after I say it as you see it. There's an imperative at this point in my mind to better grasp how you can demonstrate a therapy organization's value to third party payers in the language that they speak. Our language, the therapy language, the way we talk about our data and our research is all completely valid and valuable. However, if we're not speaking the language of those who are in a position to shift how dollars are spent, then we're going down a different path, right? There's many paths that outpatient practices can take, and lots of things that they can do besides this. But I would argue that we're in a place that if you want to be someone who cares for the population, on top of having, many different other things that you do as an outpatient practice, and therapists, I think, have superpowers and can have, you know, practices that can do a whole bunch of things. But if you want to care for the population and you want to still be considered mainstream medical providers, and I think we have to really think that in my mind is a very important component of what therapists sign up for. We're not acupuncturists, we're not massage therapists, we're not and all respect for chiropractors, but we are the mainstream rehab providers. And we don't want to, in my mind, lose that. So if the rest of the mainstream medical providers are learning how, and various stages, some haven't started yet, but if they're learning how to work as a partner with payers, as a partner with anyone taking financial risk, right, another provider type, then we have to be also. That's my big argument to the therapy community is just, I'm not negating all the other awesome things that you're doing, and this profession can go a lot of different ways. But if we are mainstream medical providers who care for patients all along the continuum of care, we have to be able to sit at those tables and have those same conversations in the same way and understand the data that the providers themselves, the physician providers, are looking at, and understand what the payers are looking at. I'll tell you one little vignette from the National Association of ACOs conference. I went to the pre-conference on Medicare Advantage, and it was fantastic. They did a wonderful job, and it was on Medicare Advantage risk, right? So lots of providers are already in fee-for-service programs like the Medicare Shared Savings Program, but they want all of their payers to be value-based payers. So they want to get into contracts. If I'm Mr. Smith's, primary care practice, Dr. Smith's primary care practice, I want to have my Medicare, my Medicare Advantage, all the different Medicare Advantage plans, and my commercial all in at risk, because I know that I'm making more money when I get into these contracts. So they don't know how to do it with MA because the playbook isn't there like it is in fee for service. So they brought MA providers to the table to kind of explain some of the ways that they think about this generally. No one is going to give away their secret sauce. We just have to try to understand how they're thinking, right? And one of the payers said something that just will always stick with me. He said, there's two kinds of providers. 95% are hagglers and 5% are collaborators. And when we get a collaborator, we know in 5 minutes that we have a collaborator, and we figure out what metrics we can work on in a contract to get them started that are going to help us and are going to help them. Because payers and providers they should be on the same page. They're not funding. They're not the funders, right? They're the payers. Payers and providers can come up with ways that those providers in the contract are helping reduce the unnecessary spend. Payers keep more, and those providers at risk keep more, and they win. Right. Not everyone can win. Right. The inpatient sites of care, if this works, and it is working, but if it keeps building, inpatient sites of care are going to lose some of their dollars. It's just the way that the math only works a number of ways, right? So going back to your original question, I want to create the imperative in your listeners and therapists' minds that we don't have an option. The money is going to those that are willing to take risk, payers and providers. And we have to know at least the way the conversations happen, the way they look at the data to find their opportunities, and then have constructive conversations to get into these alternative arrangements. And there are just so many different ways that you can offer to a willing payer, not the regular contract payer, not the one you're sitting with, yearly for 5 minutes and signing on a dotted line, the value-based network contracting part of that payer. And you're benefiting. We have to benefit from this while it's happening, because it's just going to go by the wayside otherwise.
Right. In terms of, okay, this might be a little out of left field, but I am curious how you think about this, and you're always welcome to take and say pass. In amongst the practice owner community, one of the more fashionable conversations lately has been this sort of black and white kind of conversation around, um, accepting insurance via
Yeah.
versus cash pay. Super. It's a nuanced conversation, but it's become very fashionable behind closed doors to just say it's one way or the other. I won't ask you to weigh in on that specifically, but somehow tying this back to what you're kind of talking about for the, I don't know how to articulate this, but so it's fashionable to say cash pay versus not. And then if you're I love what you said there earlier is what triggered me about this, because you said that you had met somebody that said something along the lines of 95% are sort of like just,
Hagglers.
takers, and then 5% are the collaborators,
yeah.
right? And so that really kind of raised this idea in my head of like, so using this topic as an example, 95% of the practice owners out there just want to make it a black and white conversation.
Yeah.
CMS is going to cut, and let's just yell about it. Or they're going to say, gosh, we should just add more cash pay, and that's how we make up the difference or whatever. But what you're talking about here, I think, is that for the collaborators, for the practice owners that are collaborators here,
Yep.
I think what you're saying is, if you can get to the table, if you can kind of like commit to getting to the table, to being part of these conversations, that you can renegotiate these contracts to be slightly higher. Is that like the layman's way to kind of maybe summarize this?
Yes. And
in other words, sorry,
yeah,
just to drive the point home, because I just
please.
want to say this assertively and then have you tell me whether I'm completely off the mark.
Yeah.
So in an industry right now where all these practice owners are just complaining loudly about, more cuts, and how much it hurts, what you're effectively saying, I think, is that, hey, look, in broad strokes, none of us can really directly do anything about those big cuts. But what we can do is actually participate in the conversations and get ourselves into those discussions with the right people to actually cancel out those larger cuts. I mean, that's kind of what you're saying, right? Is it like the cuts are just on paper? Really, just comes down to what's your actual contract with the payer, and let's actually get that a little higher. That's basically like what you're saying, right?
Yeah, there's a linear way to think about it, and then there's a kind of broader way to think about it. And we can start, I guess, first with linear. When when a provider decides, okay, I'm going to start entering into these value-based contracts rather than straight fee-for-service contracts, they sometimes start with just, we're going to make some small steps, and maybe that is things like, the value of a couple of the services, the prices are raised in exchange for things like, a greater level of access. So having more hours available so that their patients can be seen within 24 hours, for example. You can start very small so it's trade-offs essentially, right? You're going to identify when you start small. And let's think first about a provider at risk, because that's easier to conceptualize sometimes than the payer piece. If I'm, thinking about approaching a primary care practice, and I know that in general, without looking at data, it's generally the things that they don't manage well are, right, low back pain and arthritis, referrals to specialists, to orthopedists, right, and patients falling, imbalance, and those kinds of things, right. And so one of the stressors that they have, if they're also as a physician provider taking risk, they know their data, they know where their weak spots are. And so if we know what their weak spots are in their data, such as overutilization of specialists to see their patients diagnosed with low back pain or some kind of low back ICD-10 code. If we know that they are spending too much in that area, we can address that by offering a different solution. And we have to demonstrate how and why we're going to help them lower their spend. And therefore, we take some of that benefit in return. So it's really, we're having a conversation more about the true value in the language that the providers that are already in these contracts are taking, that they need help in areas that they can't control well.
Yeah.
I'll make a parallel. I haven't done this before, I don't think, on this podcast or any podcast, but I'm going to make a parallel to something very common right now that practices are doing, and it's one type of patient. Okay, so there's a couple of organizations that do this, like Strive Health and Evergreen Health, right? And they're both, part of larger organizations that are funded through venture capital and other things, and they're nephrology groups, and they're nephrology risk sharers. So what they say to practices is things like, we will take on what they call subcapitated risk for your patients with end stage renal disease. We will own what happens to them, and we'll bet on ourselves to do a better job than you can, because we know how to manage these patients better. We're going to build a care team around these specific patients. We know them from the claims data, who they are, right? We know who's ESRD. We're going to take that risk. We're going to do a better job. There's a lot of money at stake here, a lot of opportunity. They're very high cost, very high risk patients. We're both going to benefit. We're going to do a better job. You're going to benefit from it because they're your patients that are attributed to you, and you own their spend. So both of us are going to save. The payer's going to save because they're going to spend less. You're going to benefit from it as a practice who owns these patients. And we're going to benefit from it as a nephrology group who's an expert in helping you solve this problem. The same is going to happen. It's already happening a little, but the same is going to happen with things like ortho. And as we look at musculoskeletal spend being the number one spend, yes, ESRD is in its own category, but when we talk about the average population, musculoskeletal spend is all over crazy. And orthopedics are not going to be the solution. The reason that nephrology is different, right, is because nephrology, a physician, a nephrologist is at the center of care. We all understand, it's just a given. Someone has ESRD, end stage renal disease, that nephrologist rules the roost. Musculoskeletal is not the same, right? If I have low back pain, or I have a derangement or whatever, there are some provider type that can help me. It's not going to be the primary care provider, right? They don't manage back pain. The primary care provider knows if that patient goes for imaging or goes to an orthopedist, the spend is going to go through the roof, and they're responsible for that spend as the primary care provider. We don't want a physician to own, unless there's a red flag, right? We're screening for any reasons. A physician needs to see the patient. But for that crazy musculoskeletal spend, where still, I know therapists don't have a line of sight into this like I do and others do, but there are very few patients as a whole that are going to PT, right, as a rule. And there is a huge opportunity to redirect those patients going to ortho to PT. So to be able to show whoever owns the dollars, to be able to show them, here is specifically where your historical spend is, and here's how we're going to help you manage that and reduce it by 50%. Very doable for something like, a practice that has high spend in orthopedics. So is that, I know that's a roundabout answer, but just trying to paint the picture for therapists, like, what does it exactly mean to take risk? It means we know where the spend is, where it shouldn't be, and where it's avoidable. And we know how to avoid that spend, and we know how to make the experience better. And we know the primary care provider is incentivized to find a different solution. And the orthopedic is not going to be the solution. We're not going to be able to contract with them to help us. We need a higher value provider. And that's why I always say that therapists are very high value. That's a great example of how. Does that make sense?
It does, yeah. And so if somebody were to make this jump, is there a way to So let's paint a picture here. Let's say somewhere out there right now, there's a practice owner listening to this and they're thinking, yeah, I'm bought in, Dana. Let's go. Is this one of those things that they can somehow test or dabble with? Question mark? Or is this one of those things where you kind of got to go all in? And I'm leaving this as a broad question just to see where you go with this. But I guess, yeah, I mean, for the 5% of collaborators, the ones that are actually like thinking about this now with you, what does this look like? Do they have to put their business at risk, to try this out, or is there a way to test?
I mean, yeah, and that's such a great way to think about it. How do we test this in a small way? And it is very doable. I mean, if I'm a well-established outpatient therapy practice and I have some good, strong relationships with providers in the community, that especially primary care providers, um, if you can identify that any of them are taking or are thinking about taking financial risk, there is nothing for anyone to lose by testing out the ability of a change in their process or a change in the way that they refer or the way they access therapy, for them to test that out and see how it works. You have to be able to then track the data in the way that they track it. So, going back and tracking the claims and seeing if there's a difference between historical spend, present spend. This is a way. We could go down 10 rabbit holes on this and we only have a few minutes, but this is a way a therapist, we talk about having access to potentially the VDRC files, which are the complete data set for claims for the past 4 years. If therapists have access to that and have access to how to stratify that data to look for opportunities in their local physician practices to find spend that they can impact, then they can proactively offer those things. And if you think about it this way, the government and payers want providers to take risks. We're in administration where they're more likely to push providers in different ways to take that risk. We're going to see more new providers, new physicians that have never joined to get into these arrangements. If I'm the outpatient therapy practice and I understand how this works, I would be knocking on their door tomorrow to say, let us help you get into these relationships and let us help you succeed in these areas that we can impact, right? There's a whole bunch of different ways to go with that with new, but if you have an established provider group in your area that's in these arrangements already, bring to them a proposal where you already understand their weak points in their data. Their eyes will bulge out if they see that you see this, understand the same data that they're looking at and how you're going to offer a solution. And you just pilot a program for a quarter, right? And where you're just going to look to see if your hypothesis, pans out. As we go back and look at their, change in data, change in spend for these conditions, was what we proposed impactful on your total spend?
Yeah, that's
You can
interesting.
also offer things like, let's connect our EMRs together and let me help schedule when I get one of your patients, right? I'm going to see that they're part of your practice and I'm going to help them schedule their annual wellness visit. And I'll even I'll do their full risk screening and some other things that therapists would, can easily do as part of that annual wellness visit. Just so number one, you get them in for their visit, which is crucial because in these at-risk contracts, they have to do those visits to capture the patient's risk. It's how they get paid, right? I know another rabbit hole. We can talk about that another time. But if I'm offering as a therapy group, let's connect our EMRs together. Let me help schedule your patients that haven't had an annual wellness visit. Let me get them in for an annual wellness visit. And I'll even send you all of their screening results and anything that I suspect that you should look into when they're in the practice.
Interesting.
Those are hugely valuable pieces of information and tools for a primary care practice that's taking risk. And therapists just have to know what it is that they care about.
Thanks for listening to another episode of Strata Stories. Strata PT is a single EMR platform and revenue cycle management service for physical, occupational, and speech therapy practices that helps you achieve a 99.99% reimbursement rate. If you'd like to learn more about Strata PT and see how our EMR and RCM works, head over to stratapt.com to book a demo.